A very good morning, good afternoon, good evening to each and every one of you. I want to thank each of you for taking time out of your busy schedules to be with us today. And a very hearty thanks to the CyberSite team, Dr. Hunter Shervek, Lawrence Sicca, Lori Pacheco, and many more who have made this possible. CyberSite is an ideal platform for ophthalmologists, optometrists, technical teams, and many more all over the world. And to my understanding, 1,300 registrations or so have come in for this lecture with a total of 133 countries. And it's just such an honor to be invited to give you the lecture today titled Anterior Segment OCT for Ocular Surface Tumors. I have no relevant financial disclosures. Today, we will start off with a few interactive multiple choice questions, dive into the principles of anterior segment OCT, understand how to interpret a normal cornea, and distinguish this from ocular surface tumors and lesions, and finally end on a look into the future advancements in the realm of ocular surface imaging. So question number one for everyone. Which of the following represents ocular surface squamous neoplasia, or OSSN, on anterior segment OCT optical biopsy? So you will be seeing on your screens the poll, A, B, C, D, and we'll give you some time to go ahead and plug in your answers there. OSSN optical biopsy. Great. So we have a mix across the board, and I love that about this question. I'm so happy that there is that mix, because we're going to go through the same question, and I want you to all remember what you answered right now, so that we can then go ahead and leave the suspense till the end of the lecture to go through this. And one more question for all of you. Number two, and this is a look into the future, but very important to start to get a handle on this. On OCT angiography, which of the following is true regarding OSSN vessel area density, or VAD? I'll give you a few moments to take a look at the answer choices and plug in your best guess. Great. So we do have a leader of D. However, again, this is also across the board, and I love that about that. That just goes to show that we have, the gamut, and we're going to go through this question as well at the end. Great. So let's get started. I want to focus in on anterior segment OCT principles. Now, OCT of the anterior segment was initially introduced in 1994 using 830 nanometer wavelength of light. It had sectioning capabilities similar to that of confocal microscopy, but with better depth of resolution. OCTs, however, have now evolved over time to include wavelengths ranging from 400 to 2,500 nanometers. This technology of anterior segment OCT utilizes a Michelson interferometer, which creates an infrared reference beam of light against which multiple other beams of light are measured as they return from various ocular surface and ocular tissues at large. These reflected light beams are then collected by the device to create an interference pattern over the surface of the structure that is imaged. Now, today, we're going to focus on anterior segment OCT as it relates in its utility for the analysis of ocular surface tumors. And of course, as an addendum to that would be the ocular surface lesions. However, OCT of the anterior segment has shown great promise in identifying various other diseases such as dry eyes, keratoconus, corneal dystrophies, endothelial graft assessments intraoperatively as well as postoperatively. And here's a beautiful example of an anterior segment OCT where you can see a DSEC graft that is detached in the postoperative period. Now, anterior segment OCT has also shown great utility in the field of glaucoma, allowing for acquisition of highly reproducible iridocorneal angle measurements as compared with ultrasound biomicroscopy or UBM. And this image on the right visibly exemplifies closed iridocorneal angle. No two anterior segment OCT imaging platforms are the same. I want to emphasize that. Initial platforms were time domain devices in which a reference mirror moved in a linear fashion over the eye to generate multiple A scans. Axial resolution, however, was limited by the speed of A scan acquisition. The transition from spectral domain, from time domain over to spectral domain or Fourier domain devices has permitted faster scanning speeds and higher axial resolution. Images due to the employment of spectrometers, high-speed cameras, and broadband light sources to allow for simultaneous capturing of all A scans. While newer spectral domain OCT platforms have offered higher axial resolutions, they are limited in their overall depth of penetration of tissues as compared with time domain OCT as well as UBM. Rapidly obtained images can range from axial resolutions in the range of 5 to 7 microns. That is considered high resolution, and you can see that in purple here on your screen. Whereas ultra high resolution involves axial resolutions of less than 5 microns. More recently, commercially available swept source OCTs like the one shown in green have emerged that can acquire up to 100,000 A scans per minute. High resolution and ultra high resolution scans on OCT and of the anterior segment has allowed for a beautiful detail, increasing detail as the technology gets better and better. And I want to take you through what is normal, okay? To understand the depth in which we're going to talk about this topic, it's important to understand what normal is. You know, with MRIs and CTs, we have a radiologist to read our scans for us and interpret. But for all of us who are in cornea and ocular oncology fields, we are the ones assessing our own ASOCTs and determining what's a tumor and what's not. And so it's very important to understand the normal. Over here, you can appreciate that the thin tear film is thin and hyper reflective. The epithelium right below it with the dashed red arrow is the representation of what is normal epithelium, which is thin and hypo-reflective. You can also appreciate the level of the corneal stroma and the thickness and its consistency. And then here, the hyper-reflective corneal endothelium So I can't emphasize enough these two last images for us, as that is the basis of what we're going to do. And it's all about pattern recognition, my friends. For both normal, and this is an example of normal cornea and normal conjunctiva down below, and pattern recognition as it relates to abnormal pathologies. And this slide really sums it up. Here are your classic anterior segment OCT patterns for various corneal pathologies, benign and malignant. So let's go through it step by step. The first step, when you see something that looks abnormal on your anterior segment OCT, is to identify whether it is located in the epithelial layer or the subepithelial layer. And it's always helpful to look at various cuts in your anterior segment OCT. The differential of the imaged lesion that you take can be brought in based on whether it's epithelial or subepithelial. Now, OSSN, as you can see on the table in the leftmost column, or I should say the second to leftmost column, is located in the epithelium. It's a disease of the epithelium, whereas the other 5 lesions noted there are primarily subepithelial. Their pathology is located in your subepithelial layer. OSSN has the classic thickened, hyperreflective epithelium with an abrupt transition between normal and abnormal tissue. Now, those are your buzzwords, so I'm going to repeat it. OSSN has classically thickened, hyperreflective epithelium with an abrupt transition between normal and abnormal tissue. This is key. Now, if you know, okay, it's not an epithelial lesion predominantly, then you're looking most commonly would be to distinguish OSSN from the following 5 lesions, which would be conjunctival lymphoma, conjunctival amyloidosis, though rare, important to distinguish from all the others, conjunctival melanoma, conjunctival Nevis or Nevi, and pterygium or pterygiae. Okay, now when we look at the next column after OSSN, conjunctival lymphoma. Conjunctival lymphoma and amyloidosis both are hyporeflective. And 2 ways to distinguish these two are by their borders and their infiltrating material. In conjunctival lymphoma, all the cells are monomorphic. They're the same. They're dark. The appearance, thus, is homogeneous. And here in conjunctival lymphoma, the conjunctiva almost looks like a pseudocapsule. So another thing to keep in mind there. Conjunctival amyloidosis, as mentioned, is very rare, but it is good to know its distinguishing features. You will see lines in the subepithelial space, and those lines are very suggestive and classic for amyloidosis. We have discrete smooth borders with stippled monomorphic infiltrates in your lymphoma versus in amyloidosis, they are irregular, diffuse borders with hyperreflective linear material. Conjunctival melanoma and pterygiae will both be hyperreflective, though pterygia will be having a very different appearance and would be fibrillary in nature. And unlike conjunctival melanomas, a question has come up about this when it, already prior to the lecture from a number of audience participants. And so one of the questions that came up was conjunctival melanoma versus conjunctival nevus, and that's a great question. Unlike melanomas, conjunctival nevi will have cysts, telltale of its chronicity. These cysts are generally in the subepithelial space, yes. However, for children, many a times, you may see these cysts in the junction as well. Now, it is important in a pterygia to remember that the epithelium is normal in thickness, but can oftentimes be hyperreflective. Why is this important? Clinically, when you're looking at a patient in your clinic and you're assessing a pterygium and wondering if there's foci in there of OSSN as well, if you see thickening, that's abnormal. If you see hyperreflectivity consistent with normal actinic changes, then you can rest assured that it's a pterygium. Here is a beautiful flow diagram from a review handbook that I highly recommend those who are very passionate about this field and want to really understand the principles of it review. And I've kept the title of that review book, handbook, there for you by Carol Karp out of Bascom Palmer. I think this is a beautiful way to understand, okay, when you're talking about normal epithelium, is it hyperreflective? Is it subepithelial, hyperreflective versus hyperreflective epithelium? Is it thickened, yes or no? And then accordingly understand what it is that you're looking for. So in your practices, keeping this up by your anterior segment OCT, I think will be a great tool for all of us. In addition to anterior segment OCT being an excellent diagnostic modality, ASOCT can also be used to monitor the progress of topical chemotherapy agents, such as mitomycin C, 5-fluorouracil, and interferon alpha 2B. So here is an example of a 69-year-old male with the classic pattern of ASOCT. In the top right, thickened hyperreflective epithelium with abrupt transition between normal and abnormal tissue. After 4 cycles of 5-fluorouracil, there was clinical resolution in that OSSN. Here's a patient of mine. Another question that was brought up prior to the lecture was, how do you assess CIN and sebaceous or squamous, I should say, CIN, OSSN, epithelial versus just versus squamous cell that's invasive. So here's an example for you of a patient of mine with invasive squamous cell carcinoma. On anterior segment OCT, I've been able to actually create an anterior segment montage. And you know, in the retina field, how much we love our retinal montage to be able to identify the different locations. This is not something that has been published yet, but something that we do hope to publish in the near future is this idea that we can create on every slice and every corner of the lesion that is in question a cross-sectional aspect. So it's not just depth, but it's also location-based, and be able to create a protocol that will help us assess these patients. And not only that, but also be able to help identify your surgical margins, because a number of times what you see there is not actually where your surgical margins are. And if you're able to, on an anterior segment, be able to put together a montage of images, you will be able to identify more accurately your surgical margins should you need to go in for surgery. So the clinical pearls here: use optical biopsy with anterior segment high resolution or ultra high resolution to differentiate ocular surface squamous neoplasia from other ocular surface lesions. During medical therapy, use anterior segment high resolution or ultra high resolution OCT to monitor progress. Now, this is very important. I keep repeating this high resolution or ultra high resolution, and that's very important because in some parts of the world, like where I am in India, we don't necessarily have access to the high resolutions or ultra high resolution in every center. And that really skews whether you can use your anterior segment modality to accurately identify and diagnose or monitor lesions. So it's very important if you're getting into this field or looking for a new machine out there to really focus on your high resolution or ultra high resolution OCT for anterior segment, should there not be a financial constraint. And finally, use anterior segment OCT to identify surgical margins and plan your surgical excision accordingly. A quick look into the future, as it's very important that we actually start to identify what it is that we are going to be moving forward from anterior segment OCT, like we know now with swept source OCT and ultra high resolution OCT being sort of the leaders when it comes to ocular surface imaging. So too now has been this concept in the past few years of OCT angiography. And this is a beautiful paper out of Ocular Surface back in 2020. And identifying vascular network patterns. OCT angiography is a rapid, non-invasive imaging modality that can detect vessel network via motion contrast imaging of the red blood cells across sequential B scans. Okay, and so this paper highlighted the novel use of OCT angiography for OSSN. Now, going into this, I really want to focus in on the beautiful answers that you all have come up with. And I'm going to pause here again, because I think that it's a really good time for us to replay that poll now that we've gone through some of the concepts, and let's talk about it. So question number 1, again, which of the following represent or represents ocular surface squamous neoplasia on ASOCT optical biopsy? And let's give everyone about 30 seconds or more to really evaluate each of these lesions. And it takes some time. So I want us to give time to really analyze each of these lesions now that we know what we know. And then we will go ahead and answer this question. Okay, super. So let's analyze, okay? The leader was B, and that was 42%, so it wasn't a landslide. Followed by C, and that, my friends, is the right answer. C is the correct answer here, okay? So C is OSSN. So let's talk about that, right? When we're looking at the 3 lesions, we have to focus on the epithelial layer. If we're thinking, is this an ocular surface squamous neoplasia? Then we identify that if it has any pathology in the epithelial layer, that topmost layer, which should be hyper-reflective and thin, then it should completely alert us to, hey, could this be OSSN? When we look at C, we can appreciate that that epithelial layer, you can see the thickness on one side and the normal on the other. So you can appreciate that there is thickened hyperreflectivity in that epithelium with an abrupt transition. Do we see that abrupt transition between the abnormal on the left side of your screen in C to the normal on the right? There's an abrupt lesion, like you can almost draw it, and I wish I did, but you can see that epithelium has an abrupt transition. So that lesion that has the star asterisk in it, that is OSSN. Now we're not done here, because if this is OSSN, what are A, B, and D? And if you would like, you're welcome to put that in the chat box. What do you think A is? I'm going to give a minute or less to everyone. I want to just see what you think A is based on what we've gone through in today's lecture. And now that you've thought about A, what do you think B is?
So Dr. Nariani, we have some responses in the Q&A. If you want to open that up, you can.
Oh, perfect. Would you be able to read that for me, Lawrence? Because I'm not able to open it up on my screen.
Sure. So we have, someone said A would be melanoma, B is lymphoma, B could be pterium, D amyloidosis.
Super. Well, we have a brilliant audience out there. Okay. So A was indeed a melanoma. It was an amelanotic melanoma, but of course, we cannot tell whether it's amelanotic or not, but it's important to identify that, yes, this A is a melanoma. Okay, great job, guys. B is a conjunctival lymphoma. Remember the monomorphic cells. Remember the homogeneity in lymphoma. And D being conjunctival amyloidosis with that sort of stringy appearance, okay? And that is what is classically seen here. Super, guys. Very, very good. Going to our final question. Question number 2. We're going to play this again as a poll. On OCT angiography, which of the following is true regarding OSSN vessel area density? Now, we've not gone through this in great detail of the lecture, but I just want to identify and put some thoughts into this and make sure that we are on the same page with this. So let's give everyone a poll for this question. Super. So the answer that was before, that everyone predominantly answered, or I should say around the same, I think it was 42% answered D, and here we're saying 45% D. The actual answer is C. Okay, the vessel area density was highest within the tumor, which makes sense, right? A tumor being vascular, we want to identify that they found the most within the tumor. Secondly, followed by the adjacent subepithelial tissue within, underneath the conjunctival component. Okay, so I think this is a very important concept, but why am I bringing this up here? Well, we actually had a course called Ocular Tumors during the COVID time. Myself, Carol Shields, Carol Karp, Santosh Honavar, and a few others. And one of the things that was identified when we talked about OCT angiography for ocular surface tumors, this was back in 2020, was this concept that it's not easy to do. It's a look in the future of what could potentially be useful in identifying OSSN cases. However, the patients have to be very still, whereas with anterior segment OCT, we really have a lot more freedom and flexibility. But here, patients have to be very, very still. And it's very much technically dependent, technician dependent, user dependent as compared to anterior segment OCT. There's a beautiful paper out of Ocular Surface in 2020 on this topic, identifying 15 OSSN patients. And there, the vessel area density within the conjunctival component was significantly higher than the corneal component. The vessel area density under the conjunctival tumor was significantly higher than the corneal component. And the vessel area density was highest within the tumor, followed by the adjacent subepithelial tissue. And here are some en face beautiful imaging that show the image on the top left is your clinical photographs, followed by your anterior segment imaging in B and C. And when you look into the images of E, F, G, and H, you can identify where there is more activity going on. But again, it's a very user-dependent modality, and it still takes time, I believe, for us to go ahead and use this as a standard of therapy. So in terms of standard of diagnosis of OSSN and other ocular surface tumors, I think the baseline imaging nowadays till date is anterior segment OCT, and the ideal would be ultra high resolution. This is a beautiful image of an OSSN and showing it's on OCT angiography clinically in A, B showing its beautiful OCT angiography with the florid intratumoral thin vascular channels within the loops. And I think it's just a beautiful way to just show and demonstrate what we could be assessing in the future. I've put together a few reading materials that can really help in terms of understanding this topic more. And one of them was put out with Carol Karp, Gergi Vora, Melissa Dalavoy, and myself out of the Duke Manual of Cornea and Cataract Surgery. And like I said, there is this course that we had put out back in 2020, which is free. It's on YouTube and available for everyone to review, regarding not only ocular surface tumors and anterior segment OCT, but the gamut of ocular tumors. And I encourage everyone to take a look at that at their spare time. I am always available. So if anyone has questions or comments or anything that I can be of help with, because one of the things that I think the most important thing that I can relate in this talk today, if you take nothing else, is that we are the radiologists for the eye, for the cornea, and in the field of ocular oncology. The more normal you see, the better you are. It's like a first-year radiology resident, right? We need to see normal, normal, normal. And then we start to understand what abnormal is. And the more normal we see, the more we're going to understand what abnormal is. So I would encourage you as an exercise, if you have anterior segment OCT accessible in your practice, wherever you are in the world, to go ahead and take images of whatever you're seeing. It could be just a random corneal lesion, a Salzmann's nodule, a pterygium, what have you. But go ahead and practice visualizing and seeing them and interpreting them, because as you do interpret what is benign, you'll start to understand what, oh, this is more malignant, and start to use it as a tool to monitor the progress of topical chemotherapy as well as surgical margins. And in your post-operative scenarios, make sure to use it as an ideal tool for monitoring for any recurrence or remnants that may have settled in. So I thank everyone for their time. I am going to stop my screen share. And I am just going to take a look at the questions that have come in. Oh, beautiful. Okay, well, I think all of the questions that have come in is basically exactly that, discussing and identifying the answers to some of the questions that we've had. And I think that's beautiful. So I want to thank everyone for their kind attention. Like I said, this is the basis of what you're going to do in clinical practice. So I am always ready and available to help you. If you see any scans that you want to run by me, send it on WhatsApp, send it on email. I get a number of those. And so you're always welcome to do so at any time. I thank you for your kind attention.